Hi everyone, thanks for joining. We'll just wait another minute or so before we get started. Allow a few more people to join. Okay, go ahead and get started. Hi everyone, and welcome to this evening's webinar on maintaining peristomal skin health after total laryngectomy. My name is Alana Kelly, and I'm the clinical manager at Atos Medical in the UK. Our presenter for tonight is Catherine Chappell, who is one of our head and neck nurses. Catherine has been a nurse for 25 years, working across the community and acute settings, as well as the medical device industry. She also has extensive experience working with laryngectomy and tracheostomy patients. Tonight's webinar is the second of a three-part educational series. Research and data from an extensive laryngectomy survey will be presented with responses from over 1,700 laryngectomized patients worldwide. Catherine will also present on factors impacting peristomal skin health in laryngectomies and discuss some of the current solutions available, as well as the improvements in products that may still be needed. Skin health is a fairly new topic in our educational series, and we hope that you find it interesting and take away some learnings and helpful clinical tips. The presentation will be followed by a short case discussion, and then we'll have time to take some questions from those of you who are watching. If you'd like to pose a question at any point during the presentation, please use the Q&A function that's at the bottom of your screen, and we'll do our best to get as many of your questions answered as possible at the end of the presentation. Just a few formalities before we get started. Please be aware that by providing a virtual forum for this discussion, Atos Medical is not providing specific medical advice. The answers provided are not guidance, guidelines or endorsement. So Catherine, over to you for the presentation now.
Thanks, Alana. Hi everyone. As Alana said, throughout this presentation, we're going to be looking at maintaining peristomal skin health after total laryngectomy. In particular, how much of a problem skin irritation is, what the causes of and contributing factors to skin irritation are, and what can be done to manage skin irritation and thus improve HME compliance. Next slide, please. So looking at how much of a problem skin irritation is for laryngectomies, next slide. In 2015, the Red Associates conducted a qualitative study on behalf of Atos Medical. This showed that patients reported skin irritation when wearing adhesives. They also reported that they struggled to find products that fit due to their stomal topography. Here we've got two case studies of different skin-related issues. On the left, Eva wears her adhesives 24 hours a day. They fit her stoma shape, however they irritate her skin. Her stoma is often red, sore and itchy from the material and the pressure, and she has to use skin cream and antibiotic ointment to soothe her skin. So her main issues with the adhesives are that they irritate her skin and are uncomfortable to wear for long periods. John on the right, as you can see, has a very deep stoma and has tried many products from Atos, but still yet to find an adhesive that fits his stomal topography for a long period of time. He relies on a HME to occlude so that he can speak, and he has been unable to communicate because of the issues with his base plates. His main issues are that the adhesives don't stick to his skin, they don't properly cover the stoma or form a seal, and they're not the right shape for his stoma. So keep these two case studies in mind, as we'll be revisiting them again at the end of the presentation. The quantitative patient study was carried out in 2019, which included over 1,700 laryngectomized patients who were asked about how well their adhesives stick and whether their skin becomes irritated after wearing them. From this graph, we can see that 50% of the patients reported that the skin around their stoma has become red, raw, or irritated after wearing adhesives. And over a third of patients reported having difficulty in getting their adhesives to stay on, 38% due to their stomal topography and 33% because of sensitive, irritated, or wet skin. Next slide, please. Interestingly, these findings are also confirmed through several clinical studies on pulmonary health. You can see here that the Hilger study, the red bar, in 1996 found that 40%, and a more recent study by Piedmont-Samai in 2013 reported over 30% of patients had reported skin irritation. In these studies, skin irritation was not an outcome measure, so the actual prevalence is likely to be higher. Next slide, please. So if we consider that during the qualitative study of 2015, 50% of patients reported skin irritation, it may come as no surprise that the study also found that 47% of those patients reported taking a break from using an adhesive and thus also a HME. And of the 47% of patients that took a break, 87% of these did so at night. Next slide, please. So now we've discussed that 47% of patients who reported taking a break from their adhesives and thus a HME, and that 87% of these did so at night. Let's take a look at the clinical evidence which compares non-HME users to those who use a HME during the day only and those who use them both day and night. In 2010, Bian carried out a randomised controlled study which included 80 HME-naive laryngectomised patients. There were two groups, one control group who didn't wear HMEs and the study group who wore HMEs, but they weren't instructed whether to wear just during the day or night and day. All patients recorded coughing and forced expectorations during their first week and after 12 weeks. However, you can see from these two graphs that the coughing and forced expectoration significantly decreased after 12 weeks in the groups using HME both day and night. For those in the control group who didn't use a HME, 7% reported a reduction in coughing and 10% reported a reduction of the number of forced expectorations. Just under 4 times as many in the study group wearing HMEs during the day only reported a reduction in coughing compared to the non-HME group, and almost 2.5 times as many had a reduction in the amount of expectorations. If we then look at the participants who wore a HME both day and night, you can see that 38% reported less coughing and 52% had reduced forced expectorations. So this shows us that wearing a HME both day and night is necessary to improve pulmonary health. Next slide, please. The aforementioned quantitative study of 2019 also looked at patients' sleep experience. 48% of them reported waking during the night due to coughing. 28% of them reported to have woken their partner or another family member because of their coughing. And not only have 48% of these patients woken due to coughing, but 23% of them also reported having difficulty getting back to sleep because of their coughing, and thus not getting adequate sleep. Next slide, please. This study also looked at how often patients reported issues with their clinicians. For example, their experiences of sleep, getting the adhesive to stay in place, and problems with the skin around their stoma. Whilst patients reported that they placed great trust in their clinicians, we can see from the graph on the right that only 35% reported sleep disturbances with their clinician, compared to the 56% who didn't talk about it. The same was found regarding getting their adhesives to stay. 30% reported issues compared to the 61% who didn't, and 42% reported skin problems compared to the 52% who didn't. So we can see from this study that although patients have a high degree of trust in their clinicians, the majority of patients don't speak about their issues. It's also worth noting that the data in front of you is global data, and in the UK, the data patients have said that they had their greatest trust in their SLT. Throughout this presentation, we have looked at how skin irritation leads to non-compliance with HME use. As 47% of patients gave their skin a break, this results in reduced or suboptimal HME use, which overall leads to reduced pulmonary health, increased coughing, and increased forced expectorations and disturbed sleep. Next slide, please. COVID-19 has brought many challenges to us, but it's also highlighted the use of HMEs, HMEFs and adhesives to minimise the spread of aerosols in laryngectomised patients. COVID-19 guidelines recommend that the use of HMEs in general and HMEFs for optimal pulmonary function, and HMEFs for protection of patients and their direct surroundings by effective filtration of both inspired and expired air. Also that HMEs should be used continuously, both day and night. The use of adhesives is also recommended in several of these guidelines, as they provide an airtight seal around the tracheostoma to minimise aerosolization. Because of this, skin care has become even more important to prevent problems and ensure the compliant use of HMEs. So what are the causes and contributions of skin irritation? Next slide, please. If we take a look at what healthy skin is, the upper layer, also known as the stratum corneum, forms a protective mechanical barrier. It also protects against bacteria and viruses. The cells move up from the bottom layer of the dermis up to the most superficial layer, and the dead cells then slough off. This results in the corneocytes, or the outer layer of the skin, being replaced every 28 days. In irritated skin, the protection barrier may be lost due to peeling or desquamation, thus reducing the protection against bacteria and viruses. There are three main causes of skin irritation: mechanical stripping, where incorrect removal of adhesives without adhesive remover increases skin stripping. It removes the top layer of the epidermal cells, and any fissures and cracks from the exposed dermis pose a risk for infection. Maceration is another cause of irritation. It can be caused through oversaturation of the skin from excessive mucus. Exudate from moist desquamation causes the maceration cycle, which I'll come on to talk about in a bit more detail in a couple of slides. And a high level of moisture also breaks down the skin and loosens the adhesive. The third cause of skin irritation is contact dermatitis, which is the irritation from the presence of an adhesive on the skin. It can be classed as either irritant contact dermatitis or allergic contact dermatitis. Next slide, please. So let's take a more detailed look into each of these causes of skin irritation. On the previous slide, I mentioned that mechanical stripping removes the protective layer of epidermal cells. The skin surface is pulled away from the epithelial cells when an adhesive is just pulled off. Also, one or more layers of the stratum corneum may be stripped away, resulting in the skin appearing red and shiny. The effect of mechanical stripping may trigger a repair response, causing vascularization and increased cells turnover. Severe cases may be present with edema, erythema, and blistering. It can also cause maceration of the epidermis. There is also a risk of skin tear in cases of severe friction or shearing force, for example, if they just rip the adhesive off. There's an increase in exposure to irritants and infective agents via any fissures, cracks, or tears which may be incurred through the incorrect removal of an adhesive. It's also important to note that subsequent application of any adhesive might increase transdermal water loss and the required dermal peeling force. Also, cumulative stripped corneocytes correlate with the skin irritation, causing deepened skin furrows. So a couple of slides ago, I mentioned the maceration cycle. Stage 1, the skin is exposed to high levels of moisture from excessive mucus. It then becomes soft, pale, swollen and wrinkled, a little like our fingers and toes do if we've been in the water for a long period of time. This reduces the skin's protection against moisture, irritants, and infections. If a wound is present, this creates an immune response, triggering the release of plasma. The buildup of plasma and any other fluids exacerbate the maceration cycle and thus is counterproductive for the skin healing. Next slide, please. Maceration can cause pain and discomfort. It can also slow down the wound healing process. Macerated skin is more susceptible to infection and also to other forms of damage, such as friction from cleaning. Generally, the hydration of wounds is good for skin healing. However, with maceration, this involves excessive moisture and the contents of plasma and enzymes are counterproductive for skin healing. And again, it's worth noting that high levels of moisture can also loosen the adhesive from the skin. Irritant contact dermatitis is an inflammatory response of damage to the outermost skin layer and accounts for 80% of contact dermatitis, as was shown in Lisby and Bardsgaard in 2001, and more recently by Fonacia in 2010. When the skin is exposed to an irritant, an inflammatory response occurs, which causes disruption to the stratum corneum. The pH and hydration levels are altered, and the skin becomes more permeable to irritants and allergens, and the cycle starts over again. Also, irritant contact dermatitis may also be a minor immunological response. There are two classifications of diagnosis of irritant contact dermatitis. These are acute and chronic. Acute skin irritation typically presents with edema, inflammation, and fasciculation, and usually settles within days to weeks, whereas chronic or cumulative skin irritation presents as dry, scaling, cracking, red skin without much fasciculation and may persist for some time, especially after removal of the stimuli. Allergic contact dermatitis is an immune system response to the damage in the outermost skin layer and accounts for 20% of presentations of contact dermatitis. Histamine is released, fasciculation is observed, the inflammatory response increases the permeability, just like with irritant contact dermatitis. It may also be associated with other allergies, for example, hay fever. So a history of present and past allergen reactions, along with patch testing of various adhesives, leads to a diagnosis. But it's also worth noting that irritant contact dermatitis can often be indistinguishable from allergic contact dermatitis. And in this case, a skin allergy test, along with patient history, is the way to differentiate between the two reaction types. Next slide, please. So many laryngectomised patients undergo radiation therapy. In 2008, DERV found that radiation dermatitis, along with specific patient factors and stomal topography, all contribute to skin irritation. Radiation dermatitis can present in erythema, dry desquamation, or moist desquamation. Aging, skin becomes more fragile, and this is due to a reduction in collagen, oil, elasticity, and blood supply. Allergies, autoimmune conditions, diabetes, immunotherapies, genetic factors, and medications are all patient-specific and can increase the risk of skin irritation as well. Deep and irregular stoma shapes often require additional adhesive to get a good seal, and this additional adhesive may have a negative effect on the skin, particularly if not removed correctly, as mentioned earlier. So these contributing factors to skin irritation were also found more recently by Singh in 2018. It has been reported that significant dermatological issues occur in up to 85 to 95% of patients receiving radiation treatment, which I mentioned previously. These include erythema, dry desquamation, and moist desquamation. Erythema presentation is red and hot to the touch. This is because the basal cells are damaged and migrate to the skin surface, and a histamine-like substance is released which causes capillary dilation. Dry desquamation typically presents as dry, flaky, itchy, thickened skin. This is due to compensatory mitosis, when new cells are produced before the dead cells shed. And with moist desquamation, the dead skin cells slough off before new skin cells have replaced them, resulting in skin breakdown, and exudate is present, causing it to be moist. Next slide, please. So earlier I discussed that aging skin and other specific patient factors contribute to skin irritation. Let's explore these a little more. We know that aging skin becomes more fragile. As I mentioned, this is because of the reduced epidermal renewal, because of reduced blood supply and nutrients to the outer layers. The dermis also becomes thinner as there is less collagen and elasticity, and less oil is produced by the sebaceous glands, resulting in skin dryness and thinner, more fragile skin. Also, pre-existing conditions and comorbidities can also increase the risk of skin irritation. These include allergies, autoimmune conditions and immunotherapies, which affect the immune system, diabetes, atopic eczema, genetic factors and ethnic origin, and nutrition and hydration. We all know that a well-balanced diet and hydration are important. They're also fundamental to skin health, and some medications can affect the skin and increase the risk of irritation. A third factor which contributes to skin irritation is stomal topography. Having a deep, irregular shaped stoma can result in an increased frequency of adhesive replacement and the need for more sticky adhesives. It also increases the need for additional glue to ensure a good seal. And it can also cause difficulty in wearing a HME because of this. Next slide, please. Stomal topography in laryngectomised patients is very varied. In 2019, ATOS Medical UK conducted a survey which found that 54% of the 48 patients that took part had a deep or very deep stoma. So from this, we learn that over half of laryngectomised patients in the UK potentially might struggle to get an adhesive to stay in place. Next slide, please. So far, we've looked at the types of skin irritation and contributing factors. We've also looked at how skin irritation can cause challenges with HME use and in turn reduce pulmonary health, particularly when there is reduced or suboptimal use of HMEs. Next slide, please. So now let's look at how skin irritation can be managed and HME use, particularly at night, can be improved. Starting with managing skin irritation, patch testing by cutting a small piece of the adhesive and placing it on the arm for 24 hours, a bit like you would if you were having your hair dyed. This can be an aid for troubleshooting or a test prior to trying a new adhesive. Allergy tests can be used to diagnose an underlying cause of skin irritation also. And using a skin-friendly change routine is imperative in helping to prevent skin irritation, even in healthy skin. Therefore, using products such as an adhesive remover, which facilitate removing an adhesive, is definitely advised. The use of skin-friendly adhesives can also help improve or prevent skin irritation. Hydrogel adhesives give the skin a chance to recover and enable the patient to still wear a HME, whilst a hydrocolloid can be used with sensitive skin. Can also use the expertise of nursing colleagues and monitor and treat problematic cases and rule out infection if the skin irritation persists. Treatments required might consist of corticosteroids, the elimination of exposure, or antihistamines. So before we go on to look at hydrogel and hydrocolloid adhesives in a little more detail and how they can help with skin irritation, let's have a look at what a skin-friendly change routine is for the removal of an old adhesive, the cleaning and preparing of the skin, and also the application of a new adhesive. So first of all, as I mentioned earlier, using an adhesive remover aids a gentler adhesive removal. You do this by wiping the adhesive remover over the top of the base plate, which aids the breakdown of the glue. Using the finger lift tab on the adhesive, you can gently pull away whilst rubbing underneath at the adhesive underneath. Once the adhesive has been removed, clean the skin around the stoma with either a cleaning towel or soap and water, and then let it dry. Once the skin's dried, you can apply a skin barrier. This leaves a protective layer and also helps the adhesive stick better. Whilst waiting for the skin barrier to become tacky, rub the adhesive between your hands to warm it up and also helps to activate the glue. Then remove the backing and apply the ring in the centre as close to the stoma as possible to get a better seal. Then massage the adhesive onto the skin. The same routine in reverse may be used with hydrogel adhesives, but without the application of a skin barrier, as this will prevent it from sticking. So let's have a look at hydrogel adhesives and how they can be used at night to recover the skin whilst the patient sleeps. Hydrogel is commonly used with burns, abrasions, and for dry, dehydrated wounds. That's because they're comprised of 80% water and deliver moisture to promote skin healing. Because of this, they're gentle on sensitive skin. A study carried out in 2019 shows significant skin improvement when using Provox Luna during the night over the course of a 28-day period. It also shows that there was significantly more hours of HME use because of this. Hydrogel adhesives have a cooling and soothing effect and can be easily removed with water. However, they're not optimal for speaking. Next slide, please. A hydrocolloid is commonly used for wound healing because it's gentle on sensitive skin. It creates a moist and secure healing environment, a bit like a blister, and they are gentle to remove. Again, as with all adhesives, correct removal is recommended. The graph on the right of the screen shows the results from a clinical study which was found that less patients experienced skin irritation with the Provox Optiderm compared to Provox Flexiderm. Next slide, please. An online study was conducted by ATOS Medical UK in 2019 and was sent to 69 patients. In total, 48 took part, and of these 48 participants, 46% reported sensitive skin, and of these 46% with sensitive skin, only 8% of them used an adhesive made from a hydrocolloid. Therefore, a very small percentage of those with sensitive skin were using an adhesive which is designed specifically for use with sensitive skin. Next slide, please. So to summarise, there's a need to address skin irritation to improve pulmonary health. Throughout this webinar, we've looked at patient skin and how it becomes irritated after wearing adhesives. Also how they have difficulties in getting the adhesive to stay on due to stomal topography. We've also discussed that patients give their skin a break from adhesive use and thus HME use, and those who do this mostly do it overnight. And we've also highlighted that reduced HME compliance may lead to increased coughing and more disturbed sleep. It is possible for skin irritation to be reduced by preventative strategies such as skin-friendly change routines, adhesives that provide skin recovery, and also considering an underlying causes and contributing factors. We've also learned that there are more skin-friendly adhesives available, but these aren't widely used. And the extent of skin irritation might be underestimated, and there is a clear need to address these issues so that pulmonary health can be improved. Thank you.
Thanks so much, Catherine. As I mentioned before, we were going to walk through a case study. Catherine mentioned Eva in the very beginning of the presentation. So we just wanted to talk through some of Eva's problems and some potential solutions that may exist for Eva and her skin condition. So just a reminder of her case. She has adhesives that fit her stoma shape. The picture up over there on the left-hand side, but they irritate her skin because she does wear them 24 hours a day. So her skin underneath the adhesives becomes sore and red and a little itchy. She uses a skin cream and an antibiotic ointment to soothe her skin. She often finds that the adhesives are therefore then uncomfortable to wear for long periods of time. So the first question we have here for you, Catherine, is what could be some of the causes and contributing factors to her skin irritation?
Well, looking at her stoma, it's quite red and shiny in appearance. This could indicate signs of mechanical stripping from incorrect removal of an adhesive. So we'd need to ask her about her base plate change routine. There's also quite a bit of edema, inflammation and vesiculation present, which is signs of an acute skin irritation. Again, this signs of irritant contact dermatitis. So that would be worth exploring a little more once we've established what her base plate change routine is. So I think first of all, we'd need to establish what Eva's medical history is. Does she have any autoimmune conditions, any allergies, what medication she's taking, and what her dietary and fluid intake's like? There are some dietary recommendations to increase the intake of zinc, magnesium and protein, which all aid healing, and also keeping hydrated helps to keep the skin healthy and plump. If she's struggling with her diet, she could also be referred to a dietitian for further dietary advice and support. It'd also be beneficial to know if she's had radiation treatment, as all of these factors can contribute to skin irritation, as we've highlighted throughout the presentation.
Thank you. Looking at the picture, it looks potentially like her skin might be macerated, as you described earlier as well. So you're right, getting to the bottom of what's going on is important. You touched a little bit on her change routine and how that might impact her skin irritation. Could you walk us through a whole sort of change routine of removing a base plate and also putting one on, and what the appropriate steps are?
Yeah, well, first of all, as I said, I'd need to establish what her routine for changing her base plates is. So how she removes it. Does she use an adhesive remover wipe? What she uses to clean her skin? If she uses a skin barrier at all. I would strongly advise her, if she doesn't already, to use an adhesive remover wipe, which helps break down the glue. And as I mentioned before, that you can wipe the adhesive remover wipe over the top of the base plate, particularly if it's a semi-permeable base plate, such as Flexiderm. That helps to break the glue down and makes it a lot easier to remove. You can then use the finger lift tab to gently pull it away, but as you're pulling it away, use the adhesive remover wipe to wipe the adhesive away underneath the base plate. Again, that helps with a gentler removal. If using a hydrocolloid such as Optiderm, that starts to lift a little anyway, so you can lift the finger lift tab, and again just wipe underneath as you're gently pulling the base plate away. With a hydrogel base plate such as Luna, that requires water to remove the base plate, because the polymers in the base plate are actually water soluble. So using an adhesive remover wipe won't necessarily be effective for removing that. So a much gentler way is to just use a damp cloth and wipe that over the top of the base plate. Then I would, as I say, ask her about her cleaning, what she uses to clean it with, checking whether she is using a Provox cleaning towel, or is she using soap and water, or is she using things such as, some patients actually use baby wipes. Some of these baby wipes contain oils, which obviously you don't want to be putting on the skin, because that could cause the new base plate to start lifting prematurely, or even to slide off. And then, as I mentioned, whether she uses a skin barrier, and is it a skin barrier wipe that's designed to go underneath the base plate, or is she using a cream which is a bit thicker and a bit more oily? So I would need to find all that out, and then if she isn't using a skin barrier, then recommend that she does use one, because if you allow it to dry slightly, it becomes a little bit tacky, and that can also help to make the new base plate stick a little better as well.
Just referring back here to what she uses as well, it says she uses this antibiotic ointment. So if she's putting that on before she puts the base plate on, might that also impact the adhesion to the skin?
Definitely, yeah, because they're quite oily, aren't they? Those ointments are, so that could make the base plate lift prematurely. And then obviously any mucus or anything could, get underneath where that's lifted, and that can, of course, exacerbate the skin
off a little bit more
irritation.
easily. Yeah.
And also exacerbate the skin irritation as well.
That vicious cycle. Yeah, absolutely. Okay. Which takes us to the next point, actually, which is how does her stoma topography affect her skin irritation?
So she seems to have quite a deep and irregular shaped stoma. The case study doesn't mention, but because of this, she might need to use extra glue, as I mentioned earlier, as some patients with the deep and irregular shaped stomas do, so that they can get the base plates to stick better, giving them a good seal. She also appears to have a bit of a protruding lip all the way around the edge as well, so quite irregular really, as well as irritated.
That extra glue could be causing some skin irritation, especially if she's not careful to remove all of the glue that remains behind on the skin as well. Yeah, okay. And then next question is, how might Eva's skin irritation affect her HME compliance?
Well, again, looking at her stoma, because it's red and shiny and it looks quite sore, doesn't it? She might be one of those 47% of patients that decide to give their skin a break overnight, and maybe doing that overnight. If she's doing that, she's not necessarily wearing a HME unless she wears a tube or a stud. Obviously, as I mentioned earlier in the presentation, if she's not wearing reduced use of HMEs, that can increase coughing, forced expectorations, sleep disturbance. So her general quality of life really could potentially be affected because of that as well.
Which that is the next question. Absolutely, I was just going to ask how that might impact her quality of life.
So as
what do you see when you see patients who aren't wearing?
So
patients aren't wearing HMEs 24/7. What do you see then?
If they decide to have a break, whether that's just overnight or whether it's for a few days, quite often they will see an increase in coughing, thicker mucus, more forced expectorations. They'll complain about sleep disturbance, more so than normal when they were wearing the HMEs. So this could cause her to become fatigued, could also possibly cause her to reduce her social interactions because of the potentially increased mucus production. She might be a bit embarrassed about being out and about in public when she's having to cough quite forcefully and actually expectorating as well. Could also cause her to be more prone to chest infections as well through a suboptimal use of HMEs.
Absolutely, especially in the sort of flu season as well, being out and about without an HME. You mentioned fatigue, which you don't often consider, do you? But if she's not sleeping very well, but it's just something you don't often consider, that's a great point to make. So that brings us to the all-important question: what are some potential solutions for Eva's skin and her pulmonary health?
She could obviously wear a hydrogel overnight. As I mentioned earlier, that allows the skin it cools the skin, it soothes it, it allows it to repair overnight, also allows her to wear a HME overnight as well, which will have a positive impact on her pulmonary health. She could try possibly wearing a hydrocolloid adhesive during the day, maybe. So such as Optiderm, as I mentioned, that allows the skin to heal as well. It's designed specifically for sensitive skin. If she didn't want to wear a base plate overnight, she's still got the option of either wearing a tube or a stud to be able to wear a HME as well, and obviously again, not having a negative impact on her pulmonary health just from taking a break from a base plate.
Yeah.
If the irritation persists, I would recommend that she speaks with her clinician about whether there might be an allergic component to it, and so she might need an allergy test. She might also want to speak with her clinician about her diet and fluid intake as well, to make sure that that's optimised as much as possible to help with the healing.
You made earlier in the presentation about what we can do to optimize our skin health through diet and hydration as well. Again, something often that's not thought about. It looks from the picture that potentially she wears a button already. Difficult to see whether or not she has a voice prosthesis. I think she does, and then more difficult to wear Optiderm during the day. But yeah, all great suggestions. Do you think that we have all the products that are out there that we need for her to address all of her concerns and patients like Eva? The last question, or what other product development needs do you think might work for her?
Well, it's quite apparent that she hasn't found one that works for her yet, because of how red and shiny and sore looking her skin is. I think some development areas, because there are a lot, as I say, there are hydrocolloids and hydrogel base plates available, but they're not widely used. But obviously, even those adhesives, they have their limitations as well. I think the availability of hydrocolloids and hydrogels adhesives that stick well, so that they give a good seal to obviously improve performance, the HME efficiency. But they also need to be able to be removed easily without causing, or at least reducing, the trauma to the skin, when the skin's usually damaged anyway because from radiation treatment. So ultimately they need to be skin friendly, they need to give less reactions, but ultimately they need to be able to fit all stomal topographies, whether it's a superficial or a deep irregular shape such as Eva's. So still a little way to go yet, I think.
Yeah, difficult task for our engineers to achieve, but I know they are always working behind the scenes to make things better. So watch this space. Thanks so much, Catherine. I think we have had some questions come in ahead of the webinar that we'll go ahead and work through now.
Okay. Shall I start by asking this one for you?
Sure.
Use your experience of your speech therapy experience. Somebody has asked, is skin irritation affected by speaking valves? By speaking valves, I'm assuming they mean a voice prosthesis.
Voice prosthesis, yeah. So skin irritation affected by voice prosthesis. Not usually when it comes to peristomal, so sort of around the stoma skin health. But I suppose what I would say is that poor voicing technique. So for example, like a really high pressure voice, you end up with a little bit of back pressure, which then blows against the base plate. And anytime you're putting a lot of pressure on the base plate that is adhering to the skin, you might end up with some a skin irritation, or then having to use a stickier base plate or glue to get the base plate to stick while you're speaking. Yes, poor voicing technique, I think, can definitely add to skin irritation, but the voice prosthesis itself, no. The only irritation that you might get from a voice prosthesis that's too long or too short is on the trachea itself. But yeah, it's often something we do need to consider when working with patients, if they do have a lot of pressure with their voice, to get them to speak more relaxed and more softly, so that they don't get that back pressure against the base plate, especially when using something like a hands-free.
Definitely. And like you say, if the base plate starts lifting because of pressure, the mucus can get underneath the base plate, which makes the skin irritation worse.
Exactly. Absolutely.
Yeah. Thanks.
Just going to say, if anybody does have any other questions to post, the Q&A is there to use. I'll go ahead and run through some of the other questions that came through that I have here for you, Catherine. First one is, how soon after laryngectomy surgery can you use a base plate?
Well, as I mentioned before, Optiderm's a hydrocolloid, which hydrocolloids are used in wound healing. So therefore it can be used immediately post-op. It creates a breathable barrier, as I said before, just like a blister, and provides that impermeable barrier to bacteria and helps promote healing uninfected wounds. Although I wouldn't advise it, it's good for use post-op, but not necessarily whilst the sutures are, or if there's any exudate present, because you don't want the sutures being pulled at when you're removing the base plate. Hydrogels, I wouldn't recommend. They don't create an antibacterial barrier. However, as I said, Optiderm does create that antibacterial barrier. So once the sutures have been removed, as long as the wound is dry, then definitely Optiderm can be used.
Okay. Clinical question here, just about how often you should change a base plate post-operatively as well.
Yeah, so there's not actually a specified duration of how long you can use a base plate for. However, if it is loose, I would recommend changing it. So one, because you need to get an airtight seal to improve the efficiency of the HME and also for voicing. But also if, as we've mentioned on the last question, I think it was, if the base plate starts lifting and there's any mucus gets underneath it, that can exacerbate skin irritation as well. If the base plate appears, if it's stuck but it appears soiled, I would remove it obviously then as well, because that could cause further irritation to the skin. And obviously you want to prevent the skin around the stoma getting infected. I have actually recently watched a webinar on base plates and skin health, and they discussed that they use Optiderm base plates and they change them every 12 hours in the first week post-op, and that's so that they can visualize stitches. As I mentioned, I wouldn't recommend using it on stitches because of pulling, but there are one or two hospitals that do use it when there's stitches in situ, and as I say, they recommended changing it every 12 hours in the first week, just so that it can visualize the stitches and also check the wound underneath as well.
Yeah, I think the key, as you say, is when you are putting on top of staples or stitches, just to take care when it's being removed. We actually had a live question come in relation to this as well. Should you use barrier and remover wipes with Optiderm postoperatively?
I would proceed with caution using an adhesive remover wipe, especially if the wound, if it's a fresh suture line. If it hasn't healed, I would definitely exercise caution there. You could maybe use the adhesive remover wipe, but try not to get it on the actual suture line. And the same with barrier as well. I mean, some hospitals do, as mentioned in Eva's case study, she uses antibiotic ointment and skin creams, and I know some hospitals do actually routinely use a cream immediately post-op. So can use skin barrier, but again, I'd proceed with caution. Just make sure you don't get it on the actual suture line.
Yeah. And I often think that when you're using Optiderm post-op, there's a little bit of mucus that slides underneath it, and that makes it very easy to remove.
Yeah.
So it's much easier to remove when it is moist like that.
Mm-hmm. Yeah, definitely.
And it often will be from a little bit of sort of perspiration or mucus getting underneath after post-operatively. Okay, thank you. Thanks for that question as well. Next one is, do you recommend to have the skin rest or breathe overnight? I know this used to be taught, certainly was when I was first going through my training, but what are the thoughts on that now?
well, I've mentioned a couple of times that by doing that, that often leads to a reduced or suboptimal use of HMEs, which then in turn affects pulmonary health and can have a negative impact on that. If the patient needs a break from an acrylic adhesive like Flexiderm, they could swap to a Luna, so the hydrogel, which would allow for them to wear a HME, so obviously optimising their pulmonary health, as well as moisturising, cooling and soothing the skin overnight. If Luna's not appropriate, then they could try an Optiderm, again because it's hydrocolloid and they're designed for sensitive skin. They also aid skin healing. So there's a few options for not having to wear, not giving the skin a break as such, if you like. But if they really still don't want to wear a base plate overnight and you know want to let the skin breathe, as we used to say, then they could, as I mentioned earlier, they could wear a tube or a stud and still be able to wear the HME.
Yeah. Just very, very important to achieve that 24/7 usage, isn't it?
Yeah, definitely.
To get those good benefits. So not to go back to the dreaded bib or protector. Yeah. Next one is if a patient's base plate is intact during the day, should you leave it on overnight or change it to a new one to use just for overnight, something that's more comfortable wear like the Luna?
Okay, so if the base plate is clean, there's no soiling on there, there's no mucus around the edge of it, and it's intact, I would recommend that you leave it overnight so that you can wear the HME. There's still a good seal. Definitely leave it overnight. Don't change it for the sake of it, because every time you change it, you risk trauma to the skin. Obviously recommending a good skin friendly change routine, as I've spoken about a couple of times already, that will help to prevent it. But even with that can cause a bit of pulling and a bit of trauma. So if it's definitely intact and clean, I'd leave it and just change it. More often than not, the next morning it started lifting anyway.
You mentioned the Luna, and we actually had a question that came through when we ran this session on Tuesday about radiotherapy, and the question was asking if there's anything that can be used during radiotherapy to help with severe skin reaction, because most products, they're told that most products are not suitable to use during radiotherapy. They were specifically asking, what about the Luna? What about the Optiderm during radiotherapy?
Yeah, so I do know that some clinicians do use Optiderm during radiotherapy because it's designed for sensitive skin, and it aids healing. They're often used until the skin can't tolerate it anymore, and then if there's edema there as well, quite more often than not, they'll be switching to a tube, just to keep the stoma stable while there is the edema there. Luna, I have been asked as well in the past about Luna during radiotherapy. It's not been tested on radiated skin. Get my words out. However, hydrogel, as I mentioned, does aid healing, and it's often used in burns treatment, which is also a side effect of radiotherapy. And quite often I've heard that a topical hydrogel is actually applied to radiation damaged skin. So it's kind of similar, isn't it? So I'd say that as long as it's dry, there's no moist desquamation present, because if there was moist desquamation present, then I wouldn't recommend it to be used, because that would moisten the skin further. So as long as it's dry, then, as I say, it's not been tested, but I do know some clinicians do use it.
Yeah. Yes, we do get a lot of questions about that, using the Luna during radiotherapy, but just as you said, it's not been tested on radiated skin. Thank you very much for that. Last question we have here, you talked about patch testing And for patients who have skin allergies, obviously this is really important to do ahead of using a base plate. But do you think it should be recommended to patch test routinely prior to any base plate use? What are your thoughts on that?
I would say yes, definitely. You know, if I was going to get a hair dye or eyelash tint or something, some beauty treatment like that, I would go and get a patch test 24 hours before, because that's recommended. And I don't see why it should be any different for, you know, before you start using a base plate or changing to a new one. Especially, you know, it doesn't take much to just cut a small piece of the base plate, place it on the forearm, for example, you know, an area that's not been had radiotherapy on it, you know, just to see how the healthy skin reacts to the base, to the adhesive. Because if it reacts on healthy skin, it's going to react on radiation damaged skin, isn't it? So I would definitely recommend it. And some of my patients who are changing from either a hydrocolloid to you know, an acrylic base plate, for example, I definitely recommend it, you know, if they're changing materials.
I suppose it's also a good way to get someone, show someone what a base plate is prior to surgery as well, when you're going through the preoperative assessment. So yeah, get them used to sort of what a base plate looks like. Thank you. That was the last question. Just checking the time, and we're right on time. So thank you all so much for joining us tonight, and for our webinar this evening. And thanks so much to Catherine for presenting. We actually have recorded this evening's session, and we'll send everyone the link around to either watch it again if you'd like to go back through some more of the education, or to share with your teams or other clinicians that you know looking after laryngectomies if they may find it helpful. We appreciate you taking the time out of your evenings to listen in, and wish you all a really lovely rest of your evenings. Stay safe and stay well.